Welcome to the module on Research Design, Statistics, and Evaluating Oncology Literature. I am Elise MacDonald, Assistant Director of Pharmacy Services for the Investigational Drug Service at Stanford Healthcare in Palo Alto, California. This presentation is part of the ASHP-ACCP Oncology Pharmacy Specialty Review course, which is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. The activity is designed to be interactive with questions posed to you at several points. I will pause to allow you time to consider how you would answer the question. You may wish to write down your answer and the correct response in your handout. The disclosures are displayed on this slide. Here are the learning objectives for this module. For this presentation, I really want to emphasize it's important for you to understand what concepts you have a solid base for and what concepts you need to perhaps put a little bit more effort into learning. I realize research design and statistics can be a little daunting for everyone, especially if you're not doing it day in and day out. And so, it's okay if you have to brush up on some things. So really use this time to identify the concepts that you already know and feel pretty comfortable with. And then that will help you check off the concepts that you know, and then help you hopefully solidify some of the concepts that may not be as well known to you. This slide depicts the concepts that are covered in this presentation. Of course, there are only 8 listed on this slide. And of course, there are many more stats topics and research design topics to know and understand. However, I will point you to the handout to cover the topics that are not listed on this presentation slide. Okay, let's get started with the stats topics. With statistics, we have 2 different types of analyses. So we have descriptive type statistics and then inferential type statistics. With descriptive, we're thinking about the measures of central tendency and the measures of variability. So measures of central tendency would be mean, mode, and median. And then the measures of variability would be the interquartile range and the range of those measures of central tendency. Now, inferential statistics are the statistics that we will use when we evaluate a null hypothesis. So basically, we're going to examine the likelihood that the results were due to chance. So we're thinking about power concepts with that statement. And then we also want to think about confidence interval concepts. So how well do the results from this sample infer to the general population overall? Before we get into the nitty-gritty of types of data, what tests to use to analyze those data, etc., I want to touch upon the different types of analysis that are used in study designs. First, intention to treat. This type of analysis includes all randomized subjects. It also helps determine the treatment effect under normal conditions. And so we can prevent bias introduced by these differences in study patients in each group using the intention to treat analysis. I do want to point out that this type of analysis is the most conservative type that we have. The next one is modified intention to treat. And this analysis includes all randomized subjects who received at least 1 dose of study medication. So the difference between modified intention to treat and intention to treat is that for modified intention to treat, the subject had to have received 1 dose of study medication. Additionally, the subject data are grouped according to what the treatment the subject was randomized to, not necessarily the treatment that they received. However, for as treated analyses, this analysis includes all randomized subjects as well. However, the subject data are grouped according to what the treatment the subject actually received. So perhaps there was a dispensing error. The subject was randomized to active treatment group. However, in pulling the bottle, the wrong bottle was pulled and they accidentally received placebo for that time period. And so their data would be grouped with the placebo group versus the active group, which is the group to which they were randomized originally. Now, per protocol includes only those subjects who followed the study protocol exactly. Now, in the real world, we know this is very difficult to achieve. This type of protocol does not help distinguish between bias and treatment-related effects due to baseline differences. Additionally, it is a more generous estimate of the difference between the treatment groups, and this type of analysis could be used in a non-inferiority trial after analyzing data from the intention to treat analysis. However, that would hopefully be explicitly described in the methods section of the manuscript. One thing to consider when reading the statistical methods portion of an article is, did the authors study an adequate number of subjects? So what I'm talking to you about here is the study power. And what you need to think about is, did they enroll enough subjects to determine if there is a true difference between the treatment groups? And so the handout describes some pearls for power analyses and what makes up power, how we calculate power in more detail that I just cannot go into due to time in this presentation. And then kind of along those lines, in the statistical methods section, the authors should hopefully talk about the statistical tests that they used for each type of data that they are analyzing within the article. So that's what we will touch upon now. Let's see where our knowledge is at for types of data. So the first response question I have for you is as follows. A study included participants with ECOG performance status of 0 or 1 only. What type of data is ECOG performance status? A, continuous, B, descriptive, C, nominal, or D, ordinal? The correct answer is D, ordinal. With nominal data, we are looking at kind of a yes or no categorization or dichotomy. And so that's why that answer is incorrect. B, descriptive, is not a type of data. It's a type of statistical analysis. So that doesn't fit with this question. Continuous, you may have been tricked into thinking that was the correct answer, but for ECOG performance status, there isn't a grouping in between the numbers on that scale. So that's why ordinal is the correct answer. This slide shows the different types of data: nominal, ordinal, and continuous. With nominal, we're thinking about categories. Basically, yes or no. Do the data fit into a category? And you're thinking yes or no. For ordinal, there is an implied rank or order. So, for example, in that previous question with ECOG performance status, there is a rank or order to the scale. Now, for continuous, you're thinking more of a numerical value with no implied rank or order. So, for example, blood pressure, that is a type of continuous data because we have all of the numbers for systolic blood pressure and diastolic blood pressure along the continuum. Let's go through the different types of data in a little bit more detail. Let's start with nominal data. As I mentioned, nominal data are discrete data with no implied rank or order. And so each measurement has to go into one category. So you're thinking yes or no. So for example, dead or alive. Did the participant have an adverse event or not? Very discrete data that fits into one category only. And with nominal data, there is no mathematical relationship between the classifications or the categories that you have. And so again, you're thinking yes or no. Now, I want to point out that for percentages, meaning data that are presented as percentages, they could appear as if they are continuous data. And so as the knowledgeable pharmacist that you are, you need to be able to determine how the data are being presented and what type they are exactly. So what you want to think for nominal data is that did the patient have a response or not, for example. The next type of data is ordinal. Now, ordinal data are discrete data. They are limited categories with an implied rank or order. The distance between the rank or order is not mathematically equal. So if you have a scale and you have 0, 1, 2 on the scale, it doesn't mean that there is a 0.5 or a 1.5 between each of the other categories. Examples of ordinal data are pain scales, but not the visual analog scale, cancer staging, and quality of life. Ordinal data may be presented numerically, and so when they are presented numerically, they may look continuous, but they're not. So it's up to you to be able to distinguish between ordinal and continuous type of data. Now, when you are using descriptive statistics to analyze ordinal data, you want to make sure you're using the median as the measure of central tendency to describe the data if it's ordinal. The last type of data is continuous data. Within continuous data, we have ratio and interval, which are defined on this slide. Continuous data have defined units of measure that remain constant in between the continuum. And so within those defined units of measure, there is equal distance between each increment. And so that is the difference between continuous data and ordinal data. Examples of continuous data include platelet counts, white blood counts, and time to disease progression. As I mentioned before, data that are presented as percentages are likely not continuous data. They are more likely to be nominal data. But again, that would be up to you to determine based on how the statistics are described in the method section of the article. You also want to be careful to make sure that the continuous data are not changed to another type of data. So for example, if in the article they're talking about at least a 30% reduction in pain, you might think that would be continuous data, but it's really nominal data because we're really thinking about two categories only. Those participants who experienced at least a 30% reduction in pain, and then the other category is those that did not have that reduction in pain. When thinking about data, we also need to think about how the data are distributed. So we have normal distribution, binomial distribution, and Poisson distribution. So normal distribution is that bell-shaped curve that we're all familiar with. Another name could be Gaussian distribution. Basically, we're looking for the symmetry around the mean with the normal distribution. Binomial is independent trials with two outcomes, and so it's like flipping a coin. and then Poisson would be used when you're evaluating random events in any given time frame. Okay, now that we've talked about the types of data and data distribution, let's do an audience response question to determine what type of statistical test we would use to analyze data. Subjects were equally randomized to 2 treatment groups during a trial evaluating a new oral agent for breast cancer that causes increased glucose concentrations. Data were normally distributed. What type of statistical test is most appropriate when analyzing a difference in glucose concentrations between treatment groups? A, student t-test, B, Mann-Whitney U, C, chi-square, D, ANOVA. The correct answer is A, student t-test. In this example, we have 2 treatment groups. We are evaluating glucose concentrations. So glucose concentrations are a type of continuous data. And here, the question tells us that the data were normally distributed, which is why the student t-test is the correct answer. If the data were not normally distributed, we could think about the Mann-Whitney U. Chi-square test is not used for continuous data. It is used for nominal data. And then ANOVA is not used for 2 treatment groups. It's used for 3 or more. Let's practice some more. Subjects were enrolled in a crossover study evaluating 2 new oncology agents and placebo. Results were normally distributed. What type of statistical test is most appropriate when analyzing any differences in bilirubin concentrations in trial subjects? A, chi-square, B, Wilcoxon rank sum, C, ANOVA, or D, Wilcoxon signed rank? The correct answer is C, ANOVA. With this example, we have 3 treatment groups that are different. And so we have each of the 2 oncology agents and then the placebo. Results were normally distributed, which is why ANOVA is correct. Again, chi-square is for nominal data, so that's why that answer is incorrect. And then Wilcoxon rank sum and Wilcoxon signed rank are used for different samples, however, only when you have 2 groups. And if you have continuous data like we do in this example with the bilirubin concentrations, you would use Wilcoxon rank sum if the continuous data were not normally distributed. So when thinking about types of statistical tests, we're thinking about parametric versus non-parametric tests. And for parametric tests, you're making assumptions based on defining properties. And so basically, generally, parametric tests are more powerful than non-parametric tests, and you use parametric tests when you have continuous data that are normally distributed. So for example, the t-test, student or paired, and then ANOVA or ANCOVA, as we saw in the example questions. For non-parametric tests, you're not making any assumptions. And so you're using non-parametric tests for nominal or ordinal data. You can also use non-parametric tests for continuous data that are not normally distributed. So examples of non-parametric tests are listed here. As I mentioned before, chi-square. For nominal data, that is a type of non-parametric test. Mann-Whitney U and Wilcoxon rank sum or signed rank test. Now, the way that I try to remember this, the differences between these types of statistical tests is that non-parametric, you have nominal or ordinal, so the N and the O in both of those words, and then continuous data that are not normally distributed, not non. So those are just some little tidbits that I use to help remember which tests fall into which category. The table depicted on this slide is one that I highly recommend that you memorize or keep for future reference. It is adapted from an older article, but nonetheless, none of this information has changed since 1983. And so in this table lists the types of data. So we have nominal data, ordinal data, continuous data, and then that group is split between normal distribution and not normally distributed. And then the remaining columns describe the types of treatment groups, so 2 groups versus 3 or more groups, and then are we using the same samples like in a crossover design, or are we using different samples like in a parallel type of research design? And then each row depicts what type of data you would use for each different scenario. Now that we've talked about the different types of data and the statistical tests used to analyze those data, let's talk a little bit about measures of effect. So measures of effect is what I like to call ratio world. So we're thinking here about odds ratio, relative risk or relative risk ratio, and hazard ratio. And if you recall from early on in your training, setting up a 2x2 table. So this is depicted on this slide is an example of the 2x2 table. And to orient you, the left handmost column is the treatment. So you have your intervention, and then you have your control group. And then you have 2 columns for outcomes. Outcomes yes and outcome no. And then your total column. And so when we go through each of these examples in the next few slides, we will go through how to populate the numbers into the table in order to help us analyze data. First, let's start with a practice question. The relative risk of non-muscle invasive bladder cancer recurrence was 0.75 with gemcitabine compared with saline in subjects with low-grade disease at randomization. The hazard ratio was 0.66 with 95% confidence interval of 0.48 to 0.9. Calculate the relative risk reduction of non-muscle invasive bladder cancer recurrence. Is the answer A, 25%, B, 42%, C, 66%, or D, 75%? The correct answer is A, 25%. The calculation for relative risk reduction is 1 minus the relative risk. So in the question, we were told that the relative risk was 0.75%. So that's 1 minus 0.75 is 0.25 or 25%. So odds ratio is based on the prevalence for the outcomes. You use an odds ratio for case control and cross-sectional study designs. It should not be used in other types of study designs for data analysis. As far as the calculation, I have the equation up there, and what that equation depicts to is the 2x2 table. So thinking back to that table, A is the outcome of interest that occurred in the experimental or the intervention group. B is the outcome of interest in the experimental group, but it did not occur. And then that is all over C, which is the outcome of interest occurred in the control group over those people in the control group where the outcome did not occur. And so as far as the interpretation of the numerical value that is provided to us typically in results, if the odds ratio is equal to 1, that means the numerator and denominator are the same. And so there is no difference in the odds of the outcome. Now, if the odds ratio is less than 1, the odds of the outcome are lower with treated than those in the control group. And then conversely, if the odds ratio is greater than 1, the odds of the outcome are greater in those who were in the treatment group versus the control group. Relative risk, on the other hand, is based on incidence. So it's the direct estimate of risk, or basically the probability. It is an association between exposure and disease over time and is used for cohort and experimental study designs. Here's the calculation for relative risk. Oftentimes it's provided for you, but it is good to know how to calculate it. So in the numerator, we have the outcome occurring in the experimental group over the total number of subjects in the experimental group, all over the outcome of interest occurring in the control group over the total number of subjects in the control group. And then as far as the interpretation, it's pretty similar to the odds ratio, where if a relative risk equals 1, then there is no difference between the treatment groups. If the relative risk is less than 1, the risk of the outcome is lower in the treated participants than in the control participants. And then if the relative risk ratio is greater than 1, the risk of the outcome is greater in those in the treatment group compared with the control group. Okay, let's start with a case study to kind of solidify some of these concepts we're talking about here with measures of effect. So this study was from the SWOG S0337 trial, evaluating the effective intravesical instillation of gemcitabine versus saline immediately following resection of suspected low-grade non-muscle invasive bladder cancer on tumor recurrence. So this study was a double-blind randomized multi-center trial. The treatment groups were gemcitabine or saline, 1-to-1 ratio as far as randomization. So there were approximately equal numbers in each of the treatment groups. And then overall, just over 400 participants were enrolled. Some of the results of this study are listed in this table. These results specifically are for non-muscle invasive bladder cancer. Number of recurrences of that type of cancer was 67 with the gemcitabine group, and then 91 with the saline group. And then the 4-year recurrence rate with gemcitabine was 35% and 47% with saline. And then the hazard ratio is listed here as well as the confidence interval and p-value associated with this outcome. So thinking back to the results that I just discussed, we have gemcitabine and saline as our treatment groups. So in cell A, where the outcome occurred with gemcitabine or the experimental intervention, I had told you that there were 67 participants who experienced the outcome. Now, there were 91 participants who experienced the outcome with the control group. From the results from the previous slide, there were a total of 201 subjects randomized to gemcitabine and 205 subjects randomized to saline. So we do have a 1-to-1 distribution there, as mentioned a few slides ago. And then to complete cells B and D, you can do simple subtraction. So you would do 201 minus 67 to get the 134, and then 205 minus 91 to get 114 for cell D. Beneath the table, I have the calculation for relative risk for these data. So populating the proper numbers into the equation gives us a relative risk of 0.75. And how you interpret that into words is that the relative risk of non-muscle invasive bladder cancer in patients who received gemcitabine compared with saline is 0.75 or 75%. In the practice question, we were asked to calculate the relative risk reduction. So the relative risk reduction is 1 minus the relative risk, as I stated back on that question slide. I want to point out that the relative risk reduction is an optimistic way to present data. And in a few slides, you will better understand why I say that. Now, the relative risk reduction estimates the percentage of baseline risk that is removed due to the new therapy. So in our calculation for relative risk reduction, we can populate the data that we had. So we know that the relative risk was 0.75. So the relative risk reduction would be 1 minus 0.75, which equals 0.25 or 25%. Now, how do we interpret that in words? So in words, this is how we would interpret the relative risk reduction. It is the treatment decreased the risk of non-muscle invasive bladder cancer recurrence by 25%. And I'm stressing the numerical values and the interpretation in words because you may need to be able to understand both ways of representing these data. Okay, let's have some more practice. Calculate the absolute risk reduction of non-muscle invasive bladder cancer in patients treated with gemcitabine compared with saline among all randomized patients. Non-muscle invasive bladder cancer reoccurred in 67 subjects where gemcitabine was instilled and 91 subjects where saline was instilled. The hazard ratio was 0.66 with a 95% confidence interval of 0.48 to 0.9. Again, calculate the absolute risk reduction. The correct answer is A, 11%. So to calculate the absolute risk reduction, subtract the control event rate from the experimental event rate. So for this example, we would have the control event rate of 91 over 205, which would equal 0.44, and then the experimental event rate, which is 67 over 201, which is 0.33. So 0.44 minus 0.33 equals 0.11 or 11%. As I mentioned in the question slide, the absolute risk reduction is the control event rate minus the experimental event rate. In the first bullet point is the mathematical equation to calculate the absolute risk reduction. The absolute risk reduction could also be known as the risk difference or attributable risk. I point this out because any of these terms can be used in a situation to describe the absolute risk reduction. And so the absolute risk reduction accounts for the actual values rather than just the proportion, like the relative risk reduction accounted for was more the proportion versus the actual values. Just for reference, I've included the data from the study again on this slide. So from the previous slide, to calculate the absolute risk reduction, we have the control event rate, 91 over 205, minus the experimental event rate, 67 over 201. The numbers are 0.44 minus 0.33, which equals 11%. So how do you interpret that using words? So the interpretation of absolute risk reduction in this example is that the treatment actually decreased the risk of non-muscle invasive bladder cancer recurrence by about 11%. All right, let's have some more practice. Gemcitabine decreased the absolute risk of non-muscle invasive bladder cancer recurrence by 11% and the relative risk reduction by 25%. How many subjects will be needed in order to prevent one reoccurrence? A, 36, B, 14, C, 10, or D, 4? The correct answer is C, 10. So what we are doing in this question is calculating the number needed to treat. And to calculate the number needed to treat, you use the absolute risk reduction. So you take 1 over the absolute risk reduction, but you need to make sure you use the decimal for the absolute risk reduction percentage. So in this case, to calculate number needed to treat, you would take 1 over 0.11, which equals 9.1. And for number needed to treat, we round up because we don't have a tenth of a person. So that would be 10. The answer is C, 10. The last question asked us to calculate the number needed to treat. As I mentioned, the number needed to treat is calculated using the absolute risk reduction. And so the mathematical equation is number needed to treat equals 1 over the absolute risk reduction. And what this number equates to is the number of subjects needed to treat in order to see a benefit in one participant. Now, I want to point out that you cannot extrapolate this number needed to treat to the general population. It only describes the number needed to treat within the confines of the study as described in the article. The absolute risk reduction in this example was 11%. Now, it's important to remember when calculating the number needed to treat that you use the decimal for the absolute risk reduction. So the decimal would be 0.11. So when you place that into the equation, you have number needed to treat of 1 over 0.11, which is 9.1. Now, for number needed to treat, you want to round up because you don't have a tenth of a person. So that's why the number needed to treat is 10. So to interpret this in words would be that for every 10 patients who received treatment instead of control, there will be 1 less non-muscle invasive bladder cancer recurrence. Now, a sister to number needed to treat is number needed to harm. And we use the number needed to harm to calculate for the various adverse events. And it helps us determine basically risk benefit for treatment. Now, in number needed to harm, if we had a number needed to harm of 9.1, we would round down versus rounding up for number needed to treat. Additionally, for number needed to harm, we want the number to be as high as possible, contrary to number needed to treat, where we want the number to be as low as possible. Ideally, we would want number needed to treat to be 1, but realistically, that likely wouldn't happen. On this slide, I placed the different nomenclatures for risk and benefits. So in the first column, we have the equations for relative risk reduction, absolute risk reduction, and number needed to treat. And then in the other 2 columns, we have benefit and then risk. So for relative risk reduction, it would be relative benefit increase or relative risk reduction. Second row, absolute benefit increase, or it could be a decrease depending on what the outcome is, versus absolute risk reduction, and then number needed to treat for benefit and versus number needed to treat or harm for risk, depending again on what you're studying. Now that we've reviewed odds ratio, risk ratio, and measures of effect, let's talk a little bit more about hazard ratios. But first, let's have a practice question. A study evaluated progression-free survival associated with bevacizumab plus olaparib or placebo as first-line maintenance therapy in ovarian cancer. The authors concluded progression-free survival was longer with olaparib. What results support the author's conclusion? A, hazard ratio 0.59, confidence interval of 0.49 to 0.72. B, hazard ratio 0.85 with confidence interval 0.58 to 1.25. C, hazard ratio 1.15 with a confidence interval 0.98 to 1.29. Or D, hazard ratio 1.21 with a confidence interval 1.03 to 1.38. The correct answer is A, hazard ratio 0.59 with the confidence interval 0.49 to 0.72. So with this question and question stem, we are told that the standard of care is bevacizumab, and then we are evaluating olaparib versus placebo. And so with this question, because we have a hazard ratio, our confidence interval cannot include the number 1 in order to determine if progression-free survival was longer with olaparib or not. And so that would eliminate answers B and C. Now, A and D, the confidence intervals do not include 1. However, for olaparib to be better than placebo, we would want the hazard ratio to be less than 1, because that would mean that the treatment or the intervention, experimental intervention, is favored. That example question was to depict hazard ratio and how we interpret hazard ratios. So hazard ratio is similar to relative risk, but it is the weighted relative risk over time. And so as that indicates, the hazard ratio adjusts for change in time. And so the dependent variable is time dependent. And the interpretation is very similar as to the odds ratio and relative risk, where if the hazard ratio equals 1, there's no effect produced by the treatment. Hazard ratio less than 1, fewer events observed with comparator versus control, and then hazard ratio greater than 1, more events are observed with the comparator versus control. Often with hazard ratios, we will have survival analysis as well. Survival analysis is a time to event. So perhaps death, relapse, whatever outcome the study team is evaluating, that is a time to event. And so basically in the survival analysis, we adjust for different lengths of follow-up. And then to give the best representation of survival analysis data, you will represent the data graphically using a Kaplan-Meier curve. And you can use a Cox proportional hazards regression for multivariate analyses and a log rank test for relative event rates between the different survival curves. Now, in the survival analysis and the Kaplan-Meier curve, you will see these little vertical tick marks on the lines, and that is to account for censoring. And so censoring is incomplete or missing data. So what would cause incomplete or missing data? So maybe loss to follow-up, the study ended before the patient had the event in question, and perhaps maybe a participant withdrew for one reason or another before finishing the study. This slide shows a very rudimentary example of what a Kaplan-Meier curve may look like in an article. So on the y-axis, we have the probability or percentage of survival. On the x-axis, we have time since randomization. And often you'll have the number of lines that kind of look like a step down ladder. And each drop in the curve represents an event. And then censorship is represented by the little vertical tick marks. And so on this example, in the bottom line, I have 3 vertical tick marks. I just want to point out that there are usually many more tick marks to depict censorship, but just for sake of ease of drawing, I just included the 3 in this graphical example. Okay, let's introduce our second case. Olaparib plus bevacizumab as first-line maintenance in ovarian cancer. This trial was a randomized, double-blind, placebo-controlled, multi-center study with patients with newly diagnosed advanced ovarian cancer. And so there were about a little over 800 participants enrolled. The treatment groups are listed here. The randomization was 2-to-1, so twice as many subjects enrolled in olaparib 300 milligrams versus the control group, which was placebo. And then as a standard of care, all patients received bevacizumab. In this trial, the primary outcome was progression-free survival. There were numerous secondary outcomes. I've listed the primary one here, overall survival. They used a Kaplan-Meier analysis and stratified log rank tests to analyze these data. The authors stated that their power was more than 80% with a two-sided alpha of 0.05 or 5% significance level. And in order to meet that power, they had to have 458 events to detect a hazard ratio of 0.75. And so the events that they defined were disease progression or death. And then the type of analysis was the intention to treat. Okay, this slide shows the results for the primary outcome, which was progression-free survival. There were 474 events, which met their criteria in their power calculation. So progression-free survival with olaparib was just over 22 months, and then placebo was just under 17 months. The hazard ratio of 0.59 with a confidence interval of 0.49 to 0.72 indicates progression-free survival was longer with olaparib compared with placebo within the confines of this study. Often in trials, there will be numerous subgroup analyses that will be discussed in the results section. You may or may not have a lot of discussion on the pre-planned subgroup analyses in the methods section of the article. So why do people want to do these subgroup analyses? Well, could be hypothesis generating for future studies, perhaps. But some things to think about when you are looking at the results for the subgroup analyses is that the allocation no longer applies. So the randomization that they had, the 2-to-1 for this example in the olaparib study, does not mean that they met that allocation for these subgroups. Again, along with that, the power typically is not calculated for subgroups. So if there is no difference between the treatment groups, it doesn't mean that one doesn't exist. It just means the study wasn't powered to detect it. Often they are data dredging. So the more times you look at a study and the study data, you will have a better chance of finding some kind of a positive outcome. And so the subgroup analyses and how they present the data and how they discuss it in the results section could be misleading and overstate the data. And, you want to think about that, especially if the primary outcome isn't significant. So maybe the primary outcome was a negative result, and that has a small paragraph attributing to the description of those results for that primary outcome. And then, there's another page of different subgroup analyses. How much weight do you put into those subgroup analyses? It's just something to consider. I like to think the subgroup analyses are more for hypothesis generation for future studies, but that isn't always the case. The forest plot is a way to depict and represent the data from subgroup analysis. It's also a way to represent the data in a meta-analysis as well. So on the right-hand side of the screen is an example of what a forest plot may look like. So the x-axis, you have the numbers for this example for the results and for the hazard ratio. So a hazard ratio of 1, as we discussed earlier, is there is no difference between the treatment groups. And so below 1 means treatment group 1 is better, and then above 1 hazard ratio would mean that treatment group 2 is better. Now, each of these little bars and the squares within the bars, they actually have some meaning from the data. So the bar, the horizontal bar, is the confidence interval for that hazard ratio. And the box location, so the little square location, is what the actual hazard ratio or potentially relative risk is for that confidence interval. And then the box size depicts the number of people in that analysis. So you see the second bar has a smaller box compared with the bottom bar has a bigger box and a much shorter bar. So that means there are more subjects in that analysis there. And so the top bar and the bottom bar would depict that the treatment group 1 is better. The middle bar shows that there is no difference between treatment group 1 and 2 because the confidence interval crosses 1 or includes 1. So some pearls to think about with forest plots. Shorter bars have larger boxes, which was represented in the third bar and box example in the previous slide. Smaller confidence interval range increases sample size, and then you could be more confident with the results of that analysis. All right, another practice example. A meta-analysis with 19 trials evaluated PD-1 versus PD-L1 inhibitors in adults with cancer. 3 individuals reviewed trials for incorporation into the analysis. The funnel plot displayed asymmetry. There was no difference in overall progression-free survival between groups. The hazard ratio and confidence interval are listed here for you. The I-squared statistic was 83%. So what statement below is most appropriate? A, publication bias is not present. B, more individuals were needed to assess trial eligibility. C, additional trials should have been included in the analysis. Or D, heterogeneity exists between trials. The correct answer to this question is D. Heterogeneity exists between trials. And that is because the I-squared statistic provided for you was 83%. With I-squared statistic, that is determining the degree of heterogeneity. And so any I-squared statistic greater than 50% depicts a high amount of heterogeneity between the trials in that analysis. Publication bias is present because the funnel plot displayed asymmetry. More individuals were needed to assess trial eligibility really doesn't come into play with this because it's a meta-analysis. And then additional trials should have been included in the analysis. Again, really doesn't come into play because apparently they could only include 19 trials based on their predetermined criteria for trial inclusion. So that practice problem brings us to discuss meta-analyses. So basically, meta-analysis is the combined results from multiple studies to give the best estimate of the true outcome. Now, hopefully in the methods section in a meta-analysis article, the authors described the number of databases and which databases they used to search for studies. Selection bias could come into play depending on how the authors included what trials in the meta-analysis. Hopefully they had a predetermined set of criteria and they had independent people assessing inclusion of each of the studies. And I have a garbage can here to remind me to tell you that if you have trials that are less ideal in the meta-analysis, then your results may be less than ideal from your meta-analysis. So basically what I'm saying is garbage in equals garbage out. So this slide shows some attributes of meta-analyses. And so usually with meta-analysis, you have one focused clinical question. As I've mentioned, the authors should have described the comprehensive search strategy using multiple databases where they retrieved the studies for inclusion. And then with that, they should have described the criteria they used to select the studies to include in the meta-analysis, with independent individuals assessing each of the studies and kind of ranking them based on their criteria. So some things to think about when analyzing a meta-analysis: does combining the studies make sense? Was there any manipulation of the data across the studies? And if so, was it consistent? Because if not, you could lose data. Some data could be changed from continuous to nominal, which is okay, but it needs to be consistent throughout all the studies that were included in the meta-analysis. As I mentioned before, there's heterogeneity, and we are concerned about heterogeneity between trials that are included in a meta-analysis. So the Cochrane Q is a traditional test for heterogeneity between included studies. Now, how to interpret the Cochrane Q, we use a p-value, but it's different than the regular p-value that's based off of the alpha from the power calculation. So for the Cochrane Q, the p-value, if it's less than 0.05, then you have a high heterogeneity. And if it's less than 0.01, you have even more heterogeneity than if the p-value was less than 0.05. There are some limitations in using the Cochrane Q. Underpowered studies, you could say you have low heterogeneity when there truly is heterogeneity, for example, and then the opposite for overpowered studies. As I mentioned from the example question, the I-squared statistic is the degree of heterogeneity. So basically it's the percent variability across the studies because of the true treatment effect. It is based on the Q test, but is adjusted for the power within the study. The interpretation, as I mentioned in that example, I-squared statistic greater than 50% means high heterogeneity. Low heterogeneity is I-squared 0 to 25%. And then in between, we have moderate heterogeneity, 26% to 50%. And so if we have a high degree of heterogeneity, you as the reader of the article might want to carefully consider changing your practice based on the meta-analysis. Again, it all depends on the whole description of the meta-analysis and how you want to change your practice or not. This slide shows the different type of analysis models for meta-analyses. So we have fixed effect versus random effect. Fixed effect assumes one true result, that you have variation within the studies due to sampling. You want to use this type of effect if you do not have significant heterogeneity, and it is more powerful if the effect is similar between the studies. Random effects model, on the other hand, assumes a range of effects, and it also assumes there's variation in the study and between studies. So therefore, you'll use the random effects if heterogeneity exists between the studies. So let's introduce our third case study to solidify some of the points for meta-analyses. So this meta-analysis is looking at the use of immunotherapy with programmed cell death 1 versus programmed cell death ligand 1 inhibitors in patients with cancer. So this was a meta-analysis, but also a systematic review. The authors included articles through March 2019, and the various databases are listed here where the authors retrieved their articles for potential inclusion in the meta-analysis. They had 3 independent reviewers to determine trial inclusion, which I think is a very strong point. They used the PRISMA scoring for inclusion, for trial inclusion. Their predetermined criteria were randomized controlled trials in solid tumors comparing the efficacy of PD-1 and PD-L1 inhibitors as monotherapy or combination with standard of care. They did use a mirror process, and within that process, there were 25 trials that were excluded because they didn't have a match at all. The primary outcome for this meta-analysis was the difference in efficacy between PD-1 and PD-L1 inhibitors for overall survival. Secondary outcome was the difference in efficacy between the 2 types of inhibitors for progression-free survival and the difference in adverse events between PD-1 and PD-L1 inhibitors. As far as the degree of heterogeneity, there was no definition provided as far as what they were accepting as low, moderate, or high, but they did use the I-squared statistic for degree of heterogeneity. This slide shows the different agents and the type of malignancy from the 19 trials that were included in the meta-analysis. So we had monotherapy and combination with standard of care, and then the different types of malignancies were gastric, non-small cell lung, urothelial, and renal cell carcinoma. This slide shows the results for the primary outcomes. Overall survival, they used a random effects model. The I-squared was 37%, hazard ratio 0.75, with a confidence interval 0.65 to 0.86. And so overall survival benefit was greater with PD-1 compared with PD-L1 inhibitors. Progression-free survival, again, used a random effects model. The I-squared was 83%, quite a bit of heterogeneity. The hazard ratio, confidence interval did not cross 1, so overall survival benefit was greater with PD-1 compared with PD-L1 inhibitors. And I want to point out that in the article, figure 4 displays the forest plots for the overall survival outcomes. In the practice question, I mentioned something about a funnel plot, and I just want to touch on this for this slide. So funnel plots depict and address bias within the article, and that could be publication or selection bias of the different articles that are included. And so the interpretation of funnel plots is that the larger studies are more near the average, and the smaller studies are spread out on both sides of the average. And so in the next slide, we will show example of funnel plots. There are some limitation in using these plots, and E-figure 1 shows the test for publication bias for the particular meta-analysis in our case 3. So as I mentioned, this slide shows the funnel plots and if there's symmetry or asymmetry. So in this example, we see on the y-axis is study size, on the x-axis is effect size. The line down the middle is the null effect. We see the circles are kind of congregated around that average, and it's pretty similar on both sides, and so there is no publication bias depicted in this graph. However, in contrast, in this graph, there is quite a bit of asymmetry, so there is publication bias depicted here. We see on the null effect on the right-hand side, 5 articles versus the 2 articles on the left-hand side. So there's some kind of issue going on here with the studies that were included regarding publication bias. Let's have a practice question for non-inferiority. A non-inferiority trial evaluated palonosetron IV infusion compared with palonosetron IV bolus for CINV. A total of 212 subjects in each group were needed to meet power of 90%. The pre-specified non-inferiority margin was minus 15%. The authors conducted a per-protocol analysis after the intention to treat analysis. For the per-protocol analysis, the risk difference was minus 3.4% with a 99% confidence interval of minus 12% to 5.2%. What statement is most accurate? A, the incorrect non-inferiority margin was used. B, IV infusion is non-inferior to IV bolus. C, trial did not meet power, so conclusion is valid. D, conduct per protocol analysis before intention to treat analysis. The correct answer is B. IV infusion is non-inferior to IV bolus. And this is because the confidence interval does not go past the pre-specified non-inferiority margin of minus 15%. The lower bound only goes down to minus 12%. And then additionally, the intention to treat was conducted before the per protocol analysis, which is the correct way to conduct a non-inferiority study. So non-inferiority trials, we're looking at a null hypothesis that the treatment groups are not non-inferior to each other. I know that sounds a little bit awkward from a grammar perspective, but nonetheless, that is how we state it. And so we're thinking about a non-inferiority margin and a confidence interval threshold when interpreting the results. And so often we'll use a p-value of 0.05 to indicate that the treatments are non-inferior. However, I want to point out that if the p-value is less than 0.05, it does not mean that there's superiority between one treatment over another. You have to conduct a superiority analysis, and that superiority analysis is conducted after the non-inferiority analysis, and if that non-inferiority analysis is positive. The non-inferiority margin is based on and estimated from historical data. You take into account the uncertainty in the estimated difference between the groups, and then you'll always have to choose a proportion of the control effect that can be lost. Now, for certain disease conditions, FDA has some recommendations as far as non-inferiority margins to use. There could be some biocreep, which we did see earlier on with non-inferiority studies evaluating different anticoagulation agents. So what is the purpose of these non-inferiority trials, and why are they becoming more popular, especially in the oncology world? We conduct non-inferiority trials when we expect the treatment to be similar to whatever the standard of care is. We are already assuming that the treatment is going to be better than placebo, and there could be other advantages to the new treatment, such as maybe a greatly improved safety profile or potentially cost, which may or may not be true in the oncology world. And then it could also be unethical to conduct a placebo-controlled trial, which very well could happen within the oncology realm as well. Let's look at case 4 for non-inferiority. So phase 3 study of palonosetron IV versus IV bolus for chemotherapy-induced nausea and vomiting prophylaxis following highly emetogenic chemotherapy. The study was a randomized double-blind, double-dummy non-inferiority trial, included adult participants with solid tumors receiving HEC. Power calculation, they stated they needed 212 evaluable patients per group, and then their type 1 error was defined as 0.01. The treatment was palonosetron 0.25 milligram, IV infusion or IV bolus, 1-to-1 randomization, pretty close to that, with the 225 in the IV infusion and 215 in the IV bolus. The primary outcome was to determine non-inferiority as proportion of patients with complete response in the acute phase. And the definition of complete response that they provided was no emesis or rescue medications needed. They defined their non-inferiority margin as less than 15%. So the lower limit of the 99% confidence interval could not cross minus 15%. They did a full analysis, so they did their intention to treat analysis first, and then also did a per protocol analysis set. So I want to show some graphical representations of non-inferiority versus superiority and equivalence before we get into the results of the non-inferiority trial from case 4. So to orient you, down the middle we have the null effect at 0. It could be 1 if you're using ratio world. And then along the x-axis, we have new drug and control drug. And then the dotted lines depict the non-inferiority margin, the negative or positive. And so this graph, because the right-hand side of the confidence interval for non-inferiority does not cross that positive non-inferiority margin, the two treatment groups are non-inferior. So the new drug would be non-inferior to the control. This graph is showing the opposite of what I just described. So it's depicting the negative difference between agents. And again, we see that the non-inferiority confidence interval does not cross over the dotted line on the left. So the negative non-inferiority margin, indicating the new drug is non-inferior. This graph shows failed tests for all type of studies, so superiority, equivalence, and non-inferiority. And so to draw one of those graphs for our case study 4, the full data analysis set, the result was minus 3.8% with a 99% confidence interval of negative 12.2 to 4.7. And so you see that shown in this graph, we have the null effect of 0 because we are not working in ratio world. We have our dotted line to show our non-inferiority margin of minus 15%. The confidence interval range is shown by the line, the horizontal line, minus 12 to 4.7. The point estimate of negative 3.8 is shown with the circle, and the confidence interval does not cross that non-inferiority margin. So the palonosetron IV infusion is non-inferior to palonosetron IV bolus. And that is for both the full analysis and then the per protocol analysis. All right, let's do another example question. A study was conducted to evaluate a new test developed to improve screening for colorectal cancer. The new test identified colorectal cancer in 60 patients. Colonoscopy identified colorectal cancer in 65 patients. The positive predictive value is 3.7%. What is the negative predictive value of the new diagnostic test? A, 5%, B, 27%, C, 92%, or D, 99%? The correct answer is 99%, letter D. We need to set up a 2x2 table in order to help us visualize the data for this particular example, using the positive predictive value, the number of colorectal cancers from the new test, and from the standard therapy of colonoscopy. So before we get into populating the 2x2, let's kind of go over the 2x2, which For sensitivity, specificity, positive predictive value, and negative predictive value, I lovingly like to call it the other 2x2 table. Not to mean that it's any worse or different than the first 2x2 table that we mentioned with measures of effect. It's just that it's just different. And so this slide shows the setup for this other 2x2 table. So in talking sensitivity, we are thinking about the ability of the test to correctly identify patients with a condition. So the probability a patient with the condition will have a positive test. Higher sensitivity equals fewer false negatives. Tests with high sensitivity will be less likely to, quote, miss patients who have the condition. So in calculating sensitivity, we're thinking about true positives over all true positives plus false negatives. Specificity, on the other hand, is the ability of the test to correctly identify patients without the condition. So tests with high specificity will be less likely to identify patients as having the condition when they really do not. So if you have a high specificity, you have fewer false positives. So the way I remember that is fewer false positives, specificity, the P's in specificity and positive, and then consequently for high sensitivity, fewer false negatives is the N in negative and sensitivity. It's just little tips, how I remember these slight differences. And so the calculation for specificity is the true negatives over the sum of the false positives and the true negatives. Let's introduce the case for sensitivity and specificity. This study evaluated a non-invasive multi-target stool DNA test for screening colorectal cancer. They enrolled asymptomatic subjects at average risk for colorectal cancer. They did exclude subjects who had a history of inflammatory bowel disorders, a family history of colorectal cancer, and who had had a colonoscopy in the previous 9 years. They included about 10,000 subjects, and of those, 65 were positive diagnoses by colonoscopy, and 60 were positive diagnoses for the new test. The positive predictive value was 3.7%. That was provided to us, and the prevalence was 0.7%. So what do we need to do in order to try to help calculate sensitivity and specificity? Now, you don't have to set up a 2x2 table if you don't want to, but I find for these analyses and calculations, it is extremely helpful. Okay, so we knew that there were 60 true positives from the new test and that there were 65 from the colonoscopy. So you can see those values entered into the table. And then in the bottom right-hand corner, we know the total of A plus B plus C plus D, which is the total number of subjects who were enrolled in the study, and that was just under 10,000. Now, to populate A plus B, this 1622, we use the positive predictive value to obtain this number. So we were told the positive predictive value was 3.7%. So we need to convert that to a decimal, which would be 0.037. And that equals the true positives over X, which is the A plus B. And you solve for X using simple algebra. And that equation in math gives you 1622 cases. And then you can start doing some simple arithmetic, addition and subtraction, to obtain the information for the other cells. So we had cell A of 60 and we had cell A plus C of 65. So that's how we get 5 for cell C, the false negatives. And then we had A plus B and we had A. So we could get our false positives of 1,562. And then we had A plus B, and then the grand total to get us C plus D. And then from there, we can calculate D, which is the true negative, by that simple subtraction. And then that ultimately leads us to B plus D of 9,924. So the positive predictive value is the probability that a person with a positive test truly has the condition. So as prevalence increases, the positive predictive value increases. So it's positively affected by increasing prevalence. So they are directly proportional to each other. And then this reflects the predictive value of a positive test result in the specific population within the confines of the study. Calculate the positive predictive value. I kind of already alluded to this when we were populating our 2x2 table. So it is the true positive rate over all of the positives. So the total of true positives plus false positives. The negative predictive value is the probability that a person with a negative test truly does not have the condition. So as prevalence increases, the negative predictive value decreases. So they are inversely proportional, or it is negatively affected by increasing prevalence. And so negative predictive value reflects the predictive value of a negative test result in a specific population. To calculate the negative predictive value, we use true negatives over the sum of the false negatives and true negative values. So for case 5, this slide depicts the calculations from our 2x2 table for sensitivity, specificity, positive predictive value, and negative predictive value. So much like we did before with the measures of effect, how do we interpret the sensitivity, specificity, negative predictive value, and positive predictive value in words? So for sensitivity and specificity, how well does the test identify those with colorectal cancer? So 92% of people with colorectal cancer will get a positive test result. So that is a true positive, which means 8% of people with colorectal cancer will get a negative test result, so a false negative. And then how well does the test identify those without colorectal cancer? So specificity, 84% of people without colorectal cancer will get a negative test result. So that is a true negative. And then that means 16% of people without colorectal cancer will get a positive test result, so a false positive. So ideally, you want 100% for sensitivity and specificity, but in the ideal world, that rarely happens. And then for positive and negative predictive values, if you have a positive test result, about 4% probability that you truly have colorectal cancer is a true positive. And so that means about 96% probability that you truly do not have colorectal cancer or false positive. And then if you have a negative test result, from this example, there's about a 99% probability, your negative predictive value, that you truly do not have colorectal cancer. So a true negative. And then about a 1% probability that you truly have colorectal cancer. So a false negative. All right, let's look at another sample question. So question 11, the correlation coefficient is 0.95 and the coefficient of determination is 0.9 for a study evaluating the occurrence of vomiting with increasing doses of a new chemotherapy agent to treat metastatic non-small cell lung cancer. What statement is accurate based on these data? A, less vomiting as the dose increases. B, more vomiting as the dose increases. C, vomiting is not affected by increasing dose. Or D, need more information to determine. The correct answer is B, more vomiting as the dose increases. To help answer this question, you need to use the coefficient of determination, or R squared, which is provided to you and is 0.9. This value can determine a cause and effect relationship. And so for a purely positive relationship, the R squared would be 1. And so in this case, the R squared is very close to 1. And that means the variation in nausea is attributed to increasing the dose of the new chemotherapy agent. So question 11 was to help us start thinking about correlation and regression. So let's talk about these in the next few slides. Correlation analysis is the relationship between two random variables. With a correlation analysis, you can help identify the strength of the association between the variables, but you cannot imply causality. The correlation coefficient, or R, is the value that helps you determine the correlation. So the correlation coefficient suggests the linear relationship between your two variables. Now, because the correlation coefficient is R, it can help define the strength and direction of the relationship between the two variables. The correlation coefficient can range from -1 to +1. Now, the sign, the negative or positive sign, indicates the direction of the relationship between the variables. And then the number, so from -1 to 1, that'll determine the strength of the relationship. So as you get closer to 1, stronger relationship. This slide shows the interpretation in words of the correlation coefficient. So if your correlation coefficient equals 0 or is close to 0, there is no correlation between the two variables. So there is no linear relationship, which means the relationship is weaker between the two variables. If you have a correlation coefficient of -1, that means that the two variables are perfectly negatively correlated. So they're inversely related. However, if your correlation coefficient is +1 or close to +1, the two variables are perfectly positively correlated. Of course, to determine how to calculate the correlation coefficient, we need to know which test to use. So we can use the Pearson test or the Spearman rank order test. The Pearson test is going to be used for continuous variables. So if we have two continuous variables that are normally distributed. So because we have two continuous variables that are normally distributed, we have a parametric correlation. Now, the Spearman rank order test is going to be used based on a rank order. So maybe we're thinking here more ordinal type of data. Data that are non-parametric, or if there's a non-parametric correlation, and data that are not normally distributed. So again, for this, we are going back to earlier in the presentation when we were trying to determine the types of data that we had, and then what type of test to use in order to analyze said data. So I just want to point out the similarities here and why it is important to understand the type of data you have in order to be able to understand the correct test to use. Now, for regression analyses, we are estimating the value of one variable if given the value of a second variable. With regression, we can show a cause and effect relationship between the variables in question. So remember, with correlation, you could not determine a cause and effect. You could only determine an association. So this is the key difference between the two concepts. For regression, we are using a coefficient of determination, or R-squared value. This value defines the strength of the relationship, but not the direction. Because it is a squared value, you can't have a direction of the relationship, because when you square a negative value, you always get a positive value. So with the coefficient of determination, we are looking at the variation in one variable attributed to the variation in the second variable. So we have the X variable, which would be the independent variable, and that's selected by the study team. And then you have the Y variable, which would be the dependent variable, and that is influenced by the X variable. And then you can draw a line of best fit, which equals Y equals MX plus B, where Y is your Y value, X is your X value, M is the slope of the line, and B is the intercept of that line. And I realize this is going back to high school math classes here, and so I apologize if you never thought you would have to worry about Y equals MX plus B again. So how do we interpret the R-squared, or coefficient of determination? If your R-squared equals 0, there is no variation in Y attributed to X. If your R-squared equals 1, that means all the variation in Y is attributed to X. And now you can only predict those values within X for the sample within the population. You cannot determine the relationship outside the range of the sample. So again, we're thinking about these concepts within the confines of the study only. And then the method of least squares finds the best fit line, so your Y equals MX plus B line, for the data set in the regression analysis. And of course, we need to know which type of regression to use: multiple linear regression or logistic regression. And for multiple linear regression, we are thinking about using it with multiple independent variables. And then logistic regression would be used and preferred for ordinal scale data. And it would provide an odds ratio to us. I wanted to depict some scatter diagrams for people who are more visual learners for correlation and regression. So this slide shows the scatter diagrams for correlation. And so on the left, the top graph shows the positive correlation. So that would be the R equaling 1. You have your dependent variable, of course, on the y-axis, and your independent variable on your x-axis. And then you see the positive slope for the data points. And so that shows your R equals 1. Now, opposite of that is right below it with your negative correlation, and you have your R equaling -1. So that's why it's pretty much the opposite direction of the previous graph, where your slope is in the negative. And then the graph on the right-hand side of the slide shows no correlation whatsoever between the variables, and that is shown with the data points scattered all over the diagram. And then for regression for scatter diagrams, again, remembering that when you square a negative value, you get a positive value. So we only have a positive correlation here, shows us our R squared equaling 1. And then the line through is the line of best fit, Y equals MX plus B. And then on the right-hand side of the slide for the scatter diagram, if you have no correlation, you are not going to have any regression between the variables. And so you really can't nicely determine the line of best fit in that situation. So quickly, just some pearls for stats and learning statistics and research design. Statistics determines how certain we are about a result, but not the importance of it. So basically what I'm saying is statistical significance does not equal clinical significance. And so that's why it's really important to not only understand and read the results, but understand how they came up with those results, what tests they use, why they did what they did. And hopefully all that information is described in the methods section of the article that you're reading. If not, then there are some serious concerns if the authors did not provide that information to you. And then I also want to point out that just because you have a negative result doesn't mean that those results should be disregarded, because you might be able to glean some information from negative results. And so don't always just disregard negative results. Now, of course, there is some publication bias because we tend to see a lot of studies that are published that only have positive results versus, fewer studies that are published with negative results. All right, let's go on to question 12. A study team asked for your advice on determining a primary outcome for a randomized phase 3 trial evaluating overall survival in patients with breast cancer following treatment with a new oral agent. Which statement is the most correct regarding this new trial? A, shorter follow-up time frame is needed. B, progression-free survival is a better primary outcome. C, confounders during follow-up phase may affect results. And D, overall survival is more susceptible to bias. The correct answer is C. Confounders during follow-up phase may affect results. So because the primary outcome is overall survival, it is going to be a longer follow-up time versus a shorter follow-up time frame. Based on a consensus group, they determined that overall survival is the best primary outcome, not progression-free survival. So that makes B incorrect. And overall survival is not necessarily more susceptible to types of bias. So when we're thinking of oncology trials, let's think of some of the issues that could occur in these types of trials. So did the authors and study team use appropriate dosages and regimens for the standard of care and potentially for the agent that they're studying? Is there combination therapy? Are they using the best combination therapy out there? Or are they comparing to something that is not subpar? And then you also need to think about then the ethical standards behind that as well. How are they representing their results? What data are they providing and what outcomes are they using? And then with oncology, we know the new medications are very costly to patients, and so what is the benefit as far as the cost versus the benefit of the clinical outcomes for the patient? And with clinical outcomes, I'm thinking about not just efficacy, but I'm thinking about adverse reactions and adverse events as well. Let's go through some of the trial endpoints and outcomes for oncology trials. Overall survival is the time from randomization until death from any cause or loss to follow-up. This type of endpoint is less vulnerable to bias, and it is the most objective and widely accepted endpoint in oncology studies. However, the feasibility may be difficult, and it could be a balance between study resources and patient burden, because patients need to keep coming back. It could be expensive to keep the study open for whatever the set amount of time was for this study. So for example, for ovarian cancer, You need a large sample size, you have prolonged timeline, and potentially loss of treatment effect over that timeline when using overall survival as your primary endpoint. Now, progression-free survival is the time from randomization until objective tumor progression, death from any cause, or loss to follow-up. Generally, you'll need a smaller sample size and a shorter follow-up time frame for this primary endpoint. However, I want to point there could be some bias with it, particularly with measurement bias and assessment time bias. So for measurement bias, are the tools validated that they're using? Is there a centralized audit process to kind of help minimize that type of bias? Is there any kind of blinding that may help with the bias? So just some things to think about when using progression-free survival as a trial endpoint. And then as far as assessment time bias, is it difficult to determine the exact progression date for whatever condition or tumor progression that is being evaluated in the study? As far as clinically meaningful outcomes, there was a work group that established these outcomes for breast cancer, colon cancer, lung cancer, and pancreatic cancer. And so what they were looking at was a significant improvement in survival, quality of life, or perhaps both, depending on the cancer. And so this work group determined targets for primary outcomes and secondary outcomes in these types of cancer studies. And so with these clinically meaningful outcomes, they were influenced by the following. So what are the patient goals? What is the effectiveness of the treatment? What is the side effect profile? And what is the clinical context for the study? And then they also wanted to consider toxicity and efficacy and the balance between the two. So perhaps if a treatment is less toxic and there's less improvement in efficacy, maybe that's okay if the goal is palliative care or quality of life. But if the agent is more toxic but has greater improvement in efficacy, that might be okay if the focus is aggressive treatment and the goal of treatment is cure. So this work group determined that overall survival is the primary outcome to measure clinically meaningful results. Again, you do have a longer follow-up time with overall survival, but there really is less bias that can come into play when this is your primary outcome. There could be some confounders, so maybe potentially additional therapies after study that you might need to consider, and hopefully the study team described a bit in the method section. Now, this doesn't mean that other outcomes are unimportant, not by any means. Other outcomes are definitely important, and in your handout goes into a little bit more detail on the other types of outcomes for use in oncology trials. We have some time left for some additional practice, so I have a few slides at the end of this presentation here for more practice on choosing statistical tests, measures of effect, specificity, sensitivity, positive predictive value, negative predictive value, and correlation and regression. So let's get started. Subjects were their own control in a trial evaluating changes in platelet concentrations from baseline following the administration of 2 different oncology medications. Results were normally distributed. What type of statistical test is most appropriate when analyzing these results? A. McNamara, B. Wilcoxon signed rank, C. paired t-test, D. Mann, Whitney, U. The correct answer is C, paired t-test. So why is this one correct? Well, let's look and see what type of data we have. We are evaluating changes in platelet concentration. So that is a type of continuous data. We are also told that the results were normally distributed. So we are thinking of parametric type of test because we have continuous data that are normally distributed. And we were told we have 2 different oncology medications. So we have 2 samples that are different. And then the subjects were their own control, meaning they must have gotten both agents at one point in time during the study. And so they're comparing the results for each patient. And so the correct answer is C, paired t-test. Okay, I'd like to introduce an additional case before we get to some examples. Exemestane for breast cancer prevention in postmenopausal women. Now, this trial is a bit older, I realize. However, it still will help us with some practice for measures of effect, which is why I keep it in this presentation as an additional case study. It's not necessarily meant for the most up-to-date treatment, but it's more for the application of measures of effect. And so this study was a parallel randomized double-blind placebo-controlled study conducted throughout the world at different centers. The primary outcome was incidence of invasive breast cancer. Treatment groups included exemestane or placebo in a 1-to-1 fashion as far as randomization. Also, there were some ER-positive breast cancer participants in the exemestane group and in the placebo group as well. So this leads us to our next practice question. The relative risk of invasive breast cancer was 0.25 with exemestane compared with placebo. Calculate the relative risk reduction of invasive breast cancer in ER-positive patients treated with exemestane compared with placebo. So is the relative risk reduction A, 12%, B, 25%, C, 75%, or D, 95%? The correct answer is C, 75%. So remember back from the beginning of this presentation, we said to calculate the relative risk reduction, you subtracted the relative risk from 1. So that means we have 1 minus 0.25, which would equal 0.75. And then converting that to a percent is 75%. Okay. Extra question number 15. Calculate the absolute risk reduction of invasive breast cancer in ER-positive patients treated with exemestane compared with placebo. The annual incidence of invasive breast cancer was 0.09% with exemestane and 0.34% with placebo. Is the absolute risk reduction A, 0.02%, B, 0.25%, C, 0.74%, or D, 0.81%? The correct answer is B, 0.25%. So to calculate the absolute risk reduction, we take the control event rate minus the experimental event rate. And so for this example, we need to use the annual incidence of invasive breast cancer because in this study, they were looking at the incidence of invasive breast cancer, and these values are just the annualized incidence of invasive breast cancer. So we have 0.34% minus 0.09% to give us 0.25%. As we mentioned, exemestane decreased the absolute risk of invasive breast cancer by 0.25%. How many subjects will be needed in order to prevent one breast occurrence? A, 5, B, 11, C, 123, or D, 400? In this question, we are ultimately looking for the number needed to treat. So we calculate the number needed to treat by taking 1 over the absolute risk reduction. So we are told that the absolute risk reduction of invasive breast cancer is 0.25%. So now remember, we need to convert that to a decimal. So to calculate the number needed to treat for this example, it's 1 over 0.0025, which equals 400. In this trial, there was a significant difference in musculoskeletal arthritis. Exemestane increased the absolute risk of arthritis by 2%. How many subjects will be needed in order to have 1 report of arthritis? A, 2, B, 5, C, 50, D, 75. In this example, we are looking for the number needed to harm. So the number needed to harm is calculated just like the number needed to treat. So in this case, we are told that the absolute risk of arthritis with exemestane is 2%. We need to convert that to a decimal. That would be 0.02. So 1 over 0.02 is actually C, 50 is the correct answer. This slide shows how you would set up the 2x2 table for calculating the measures of effect if you're more visual and need the table to help you calculate the relative risk reduction, absolute risk reduction, and number needed to treat. And in this case study, we were looking at the ER positive specific population. So if you're given multiple populations, make sure you are reviewing and including the correct data into your 2x2 table. This slide shows the calculation for the relative risk and subsequently for the relative risk reduction. Again, relative risk reduction, 1 minus relative risk. We were told the relative risk was 0.25, so our relative risk reduction is 75% in this specific sample of the population in the study. This slide shows the calculations for absolute risk reduction and number needed to treat. So as you recall, the absolute risk reduction, we were using the annual incidence as depicted in the specific question. And the absolute risk reduction was calculated to be 0.25%. So I want to show you the difference between that number and the relative risk reduction, which was 75%. And so just based on the numbers, if you were only given the relative risk reduction, you would think this new drug was phenomenal. But what we really care about in practice is the absolute risk reduction. And so with the 0.25% for the ER positive group, we see that the new drug maybe doesn't hold up to what we thought it might. And then below that, the calculation for number needed to treat is provided to you. Again, I want to point out converting the percent to a decimal. And then on this slide shows the number needed to harm calculation with the correct value of 50 for number needed to harm. Again, we would maybe want a little bit higher number needed to harm. 50 is pretty low, but nonetheless, that's what the data provide for this example. Next practice question. A study was conducted to evaluate a new test developed to improve screening for colorectal cancer. The specificity of the new test was 84%, and the sensitivity is 92%. Which statement is most accurate regarding this new test? A, likelihood to miss a diagnosis. B, expect fewer false negatives. C, expect many false positives. Or D, low likelihood to make a positive diagnosis. The correct answer is B, expect fewer false negatives. The sensitivity of the test is high at 92%. Therefore, one would expect fewer false negatives and less likely to miss a diagnosis. The specificity is higher for this test at 84%, one would expect fewer false positive diagnoses. And one would also expect less likely to identify patients as having the condition when they really do not have it. Another practice question. A study was conducted to evaluate a new test developed to improve screening for colorectal cancer. The new test identified colorectal cancer in 379 patients. Colonoscopy identified colorectal cancer in 823 patients. The positive predictive value is 23.6. What is the negative predictive value of the test? The correct answer is D, 94.7% for the negative predictive value of the test. Remember, to calculate the negative predictive value, you take the true negatives over the true negatives plus the false negatives. And so you can gain that data by populating the 2x2 table as well, and then performing that calculation. This is the other 2x2 table for this second sensitivity, specificity, negative predictive value, and positive predictive value example. So you would go ahead and populate the cells with the information provided in the question, and then perform your simple arithmetic for addition and subtraction to complete the remainder of the table. This slide shows the completed table for you. And then on this slide, I provided the calculations for sensitivity, specificity, positive predictive value, and negative predictive value if you want to practice some more using the values from the previous 2x2 table on the previous slide. Okay, one last practice question. We are almost at the end. The correlation coefficient is 0.98. and the coefficient of determination is 0.96 for a study evaluating a new chemotherapy agent to treat advanced pancreatic cancer. What percentage best estimates the variation in the outcome due to the independent variable? A, 2%, B, 19%, C, 96%, or D, 98%? The answer to this question is C, 96%. The question is asking you for the variation in the outcome due to the independent variable, which is exactly the definition for coefficient of determination, or R squared. Remember, with R squared, you can determine the cause and effect relationship. Conversely, with the correlation coefficient, or R, you can only show an association or determine an association between the variables. You cannot imply causality with the correlation coefficient. This concludes this presentation. I really appreciate you participating.